Welcome, 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 everyone. I want to do a nice little quick check to make sure everyone can see my screen as I share. Let's see. Awesome. How you doing, Robert? You made it.
Yep. It's next week. I won't be here next week.
Oh,
Yeah.
okay. Can you see the agenda on the screen?
Yes, ma'am.
Great. Awesome. So I need you to help me tonight just to make sure. Let me know that you're able to see everything once I post it up.
Yes, ma'am.
Okay. Okay.
Hey, it's Andy. I'm here, but I don't really have video because I'm in Australia for a conference. So,
Okay. Okay. Well, thank you for joining, Andy. Had a safe trip there. Everything going well?
oh yeah, just long. But yeah, it's going well.
Awesome. Hi, Courtney. How are you?
Hello, I'm well. Can you hear me okay?
Yes,
Okay,
yes,
I just
yes.
making sure. Hey, Andy.
Hey,
Myrna? Is that Myrna, Miss Scott?
Yes, ma'am. Hi.
Hi, how are you? Welcome.
Well, thank you and welcome too.
I don't think we met you last week. Is that correct?
Right. I had my cell phone and I wasn't able to, get my
Okay.
picture up.
Okay. Well, we're going to go ahead and get started at 6:01, and we have a lot to cover on tonight. So as you can see, let me go ahead and read our statement here right quick. Okay. Dr. Sellers Educate is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. To receive contact hours, you are required to stay for the entire program or watch the full recording and complete the evaluation. Your evaluations, they will be available at the end of the course. And please make sure you complete those evaluations and provide us helpful feedback so that we can continue to move forward and make improvements where improvements are needed and continue those things that need to continue, et cetera. So thank you again for joining us on this afternoon. The agenda is up on the screen. We're going to do just a soft check-in, making sure everybody's okay, making sure you've had a good week. Do you have any questions before we move forward?
Um,
Thumbs up. I'm sorry, go ahead.
yeah, I guess a couple of them. So whenever I was looking through let me get the name of the book right, the Wilson and Whitman Price book.
Yes, sir.
It was talking about chapter 4 and chapter 5 covered domain 1. Um, and then it was like 6 and 7 covered domain 2. So is 4 through 7 domain 1, or I'm just confused on that.
Did you look on your sheet? Because I have everything outlined on your sheet as
I
well.
did. I
Mhm.
did. I was just confused why the book said that. That was weird.
So when we look on the book, chapter professional values and capabilities is chapters 4 through 7.
Uh,
Mm-hmm. And
yeah.
so tonight we're going to do 4 through 7. We'll be able to take care of that. The introduction was what we did last week.
Yeah. Okay. It was just
Mm-hmm.
weird. It just looked weird to me. Okay. Thank you for clarifying that, though.
Yeah. So it's set up pretty straight in the front. So if there's a typo somewhere, I'll need to make sure I make that correct. But week 2 on our CHSE exam prep outline for week 2, it says reads chapters 4 through 7, and 4 through 7 looks at your professional values and capabilities. And then next week we will start reading chapters 8 to 13. And that's where we're getting into part 3, where it says healthcare and simulation knowledge / principles. And then we'll move to week 4, which is chapters 14 through 17. And that's the week we're going to break that chapter down, because 40% of your exam is coming from your educational principles applied to simulation. So we'll only do part of that chapter, that section that week, and then we'll pick up the following week on week 5 and do your 8 through 21, which is the other portion of that domain. And then we'll finish up week 6 looking at simulation resources and environment, which in our book is chapters 22. Actually, it's chapter 22 and 23, and then 24 is your practice test. Okay, good question. Thank you. Hi, Miss Free. How are you doing today?
Good afternoon. I'm doing well. How are you?
I'm doing well, doing well, doing well. Okay, so we'll go ahead and start our dictionary terms on tonight. Let's see, pull that up. We'll do 10 from our dictionary. Can everyone see the dictionary on the screen? Correct? No?
I cannot, no.
Okay. Stop. So we're probably going to do a lot of stop and start. Okay. Thumbs up, yes. Thumbs down, no. Can we see the first word tonight is actor? We're good? Awesome. Okay. And we're just going to go through those terms. And like I said earlier, we won't get through the entire book. But I do encourage you to go through the terms on your own and just kind of make some nice connection with the terms, just in case you're on your exam, or when you are on your exam, you'll see terms. If you can't quite figure out your answer, at least you know the definition, you're able to navigate safely. So actor will be our first term on tonight. And we have actors in our simulations. It could be an embedded participant, role player, simulated patients, simulated persons, standardized patients, standardized or simulated participant. They usually represent a person playing another role within the simulation based on the simulation experience. In addition to your patients, such as a family member, a person who has probably not lived through the situation they portray, but brings skills in playing the role. Our next term for this afternoon, let's see, artificial intelligence, which we're doing a whole lot of now. AI is running at a very fast rate, the highest faculty of mind, capacity for comprehending general truths, and AI is embedded into a lot of our simulations as we are seeing them to now, defined as a machine-based system that can, for a given set of human defined objectives, make predictions, recommendations, or decisions influencing real or virtual environment. Next is augmented reality. It's a type of virtual reality in which synthetic stimuli are registered with a superimposed on real objects, often used to make information that is otherwise imperceptible to human senses. It's a spectrum of mixed reality simulation that is partway between the real world and the virtual world. Okay. We're going to look at briefing. Briefing is the pre-briefing serves to set the tone for the upcoming learning experience, serves to prepare and orient learners to the simulation environment. The briefing in advance of the simulation activity consists of several components. It's usually during our pre-briefing stage that we establish our fiction contract. We make sure we understand the goals, the objectives, shared with our learners, providing logistic details about the session and pledging to respect the learners as well. This is an opportunity to create psychological safety and making sure we're maintaining that. This is where we start that in our briefing, pre-briefing time before we start our actual simulation. Briefing materials may include a verbal or recorded or written handoff report or other referrals such as the ambulance, and just giving examples of ambulance participants receive a notification from the ambulance personnel regarding the patient being transferred to their facility with the gunshot wound. So it's during the pre-briefing briefing stage that we make sure we really establish psychological safety and go over all the those logistics, timelines for your simulation, and a moment for everybody to review your simulation area, simulators, and making sure everybody has everything and understanding of the scenario itself to be very successful. In our debriefing is what we do at post-sim, a clinical debriefing, facilitated discussion after an actual clinical event designed to promote reflection, right? And improve outcomes for the individual team, as well as the patient in this clinical setting. Defined as an individual team formally reflecting on the performance after a task or shift has been done. Closed loop communication is very critical, especially when we're looking at what? Teams, and also avoiding adverse sentinels events. Closed loop communication is very critical. Consists of exchanging clear, concise information and acknowledging receipt of the information to confirm its understanding. The communication is addressed to a specific person on the clinical team by name, and the recipient repeats the message back to the sender. Such communication enhances patient safety. That's the big thing. Patient safety by preventing confusion, ensuring that teams operate under a shared mental model, and that a specific person is responsible for completing the task. Competency. Competency is having the necessary knowledge or technical skill to perform a given procedure within the bounds of success and failure rates deemed compatible with acceptable care. So we're all doing our simulations to help our students achieve competency. If we're just doing psychomotor motor skills, looking at our validations, testing competency so that our students are able to go forward and be safe in their respective places. Conceptual fidelity in simulation ensures that all elements of the scenario or case realistically relates to each other so that the patient makes sense as a whole to the learner. Conceptual fidelity. Are our vital signs lining up with hypertension? You know, does the patient, when they look at those things, are they able to put it together? Does it really all line up from labs all the way down to the patient presenting to really tie that in for your acidosis, alkalosis, your DKA scenarios? Okay, so we're going to start right here with our definitions. We will come back at a next time and actually look at more definitions, but I encourage you to go through your scenario, your dictionary, and actually highlight some of those, quiz yourself, and make sure you have a great understanding of those definitions as it's related to simulation. So what we're going to do now, we're going to go right on into our first run of questions. We will be starting in chapter 4, going through chapter 5. We're going to do 4 and 5, and then we'll take a break, our first break. Mm-hmm. Clear the screen up. Let's put our chat box up. So just like we did on last session, whenever I read your question, you will put your answers in the chat box. Okay? I think I'm going to stop sharing the calendar. We'll go here. This is what we're going to do tonight. Everybody will put their answer choice in the chat box, and then we will announce the answer, and then we will talk about our rationales. Okay? All right. Remember, thumbs up, thumbs down. All right. Awesome, awesome, awesome. Y'all ready to let's roll tonight, this afternoon? All right. So we're in chapter 4, page 41. All right. Leadership, the first one. Leadership in simulation includes which of the following attributes? And this chapter is talking about leadership in simulation. A, simulation knowledge. B, laboratory setup skills. C, succession planning. D, national recognition. Correct. Our answer is C. Who would like to share? How did you arrive to the decision of C being your answer choice and A, B, C being incorrect?
because the chapter talks about succession planning and how we can grow novice educators into expert educators, and looking at the different skill sets that each one of them have, and simulation knowledge, laboratory setup skills, and national recognition, to me, are more like parts of the job as opposed to succession planning.
Exactly. And true attributes to a leader, right? Looking at that leader, what are the attributes of a leader or the leadership, the leader? Yes, great job. Thank you, Robert. Thank you. Leaders make short and long-term goals and are passionate about the organization, continue regardless of whether they are appointed the leader. Setting up laboratory skill stations is a managerial task. Simulation knowledge may be an attribute of many healthcare educators, and some may not display leadership qualities. National recognition may be for simulation research scholarship or service besides leadership. If thinking about our succession planning, they talk about succession, you know they're talking about leaders, your leader, who's going to do next. Great job. Number 2, a leader's moral obligation to simulation learning includes A, developing scenarios, B, debriefing learners, C, understanding simulation terms, D, disseminate novel ideas. Correct. Yes, our answer is D. D is our correct answer. Disseminate novel ideas. Who would like to share your rationale? Either in the question itself, what was some keywords for you, or tell me why A, B, C were not the correct answer choice. Or you can tell me why D. You can do a combination of both. But D is our correct answer.
Well, in simulation, you have to have ideas come out, and whenever you're disseminating novel ideas, you're basically trying to teach your other coworkers, like your advanced beginners, your novice educators. And as long as you're disseminating novel ideas, you're continuing to grow the simulation field.
Yeah, exactly. And that's a moral obligation we are as leaders. And even as we get our CHSE, as those experts, we're to be moving that knowledge forward. When you look at developing scenarios, your leaders don't always have to do that, right? That could be anyone who's learning how to do that on your team, right? But it says an obligation of that leader, right? Debriefing learners. Does it have to be the leader that's doing your debriefing? Not specifically. It's not their obligation. Understanding simulation terms. Is that an obligation of the leader? Our best choice is disseminating those novel ideas, those new things that are happening. What are the new things you're doing in your sim? What is that new moulage technique you're moving forward? What are you doing differently for your foundations course? What are those novel things that are not being done that we can move forward in our simulation community to help others and grow knowledge? Simulation leaders have the moral obligation to share new and novel ideas so other simulation educators can have learner benefits. Developing scenarios may only affect the people who use them. Debriefing learners do not take leadership per se, but a trained debriefer, now that's critical, right? They do, especially in North Carolina, our board of nursing, you need to make sure that your debriefers are trained, right? Understanding simulation terminology is the responsibility for everyone who works in a simulation laboratory. Okay, a new simulation educator has been orienting with a mentor. The new educator requests to add some detail to the scenario being developed for advanced practice nurse learners. The new simulation educator is demonstrating that they are at which stage of beginner's development? A, novice, B, advanced beginner, C, competent, D, proficient. Beginners. Correct, it's competent. So let's talk about this one. Who would like to share? Why wouldn't it be novice, advanced beginner, or proficient? What in your question really said, I covered up everything, I would say this is a competent.
For the descriptions, it's competent says that they collaborate on scenario development versus novice. They don't really do that. Advanced beginner don't really do that. And proficient, they can facilitate independently. So competent kind of was the best fit.
And in your question, it says what being developed for the new nurse educator, a new simulation educator has been orienting with a mentor. The new educator requests to add some detail to the scenario being developed by the advanced practice nurse learners. The new simulation educator is demonstrating that they are at which beginner stage. So they're able to add and start collaborating and also add something to it, right? Okay. The competence is the stage, or competence is the stage at which the person can assist by adding knowledge. They're starting to bring some in there, getting a little bit, they understand the fundamentals, and now their confidence is up too, but they know how to add that knowledge and put it at the right place within that scenario setting. To the situation, novice educators are limited in their capacity to change things and may be somewhat inflexible. They're really straight by the stages. Right? They follow everything. They have their scenarios. They have the simulation itself, and they read it. Your novice educator, right? No troubleshooting. They're going to look to others to troubleshoot and probably would call first, right? Need technical training through the manufacturer. So your advanced beginner can recognize parts of the situation. Right? They can recognize it. Your advanced beginners can recognize parts of the situation. Your proficient practitioners can see the big picture and are confident to change plans if needed, not just add to them. So the key thing in this situation is they were able to add, right? And I love what Courtney said, some collaboration there. They feel like they can add to the conversation. Please make sure you highlight banners. And I believe there is a document in your folders that really talk about banners, and you're able to see it in practice in simulation. Remember, it's not the definition of the theories, but it is the how is it overlaid in our simulation world when they're looking at the banners development. What does that look like in action? Being able to pull that out, just like we did here with this question. Number 4, the expert simulation educator needs more understanding of their mentorship role during orientation when they ask the new simulation educators to A, observe several simulations, B, create a scenario, C, demonstrate debriefing, D, use an existing scenario. Our correct answer is B. Who would like to share their rationale for choosing B? Oh, let's start from looking at the question. What is your question asking you?
It's asking you which part needs more understanding.
Mm-hmm.
And
So
they're not creating a scenario right off. Like you just said, they're going to be asking for input. You're going to give them stuff that's been tried and true, like using an old scenario. You're going to have them observe things to try to learn their flow. And then demonstrating debriefing, they're going to have some type of faculty member there with them while they're demonstrating it. So B was the best answer.
Exactly. They're going to even have a script, right? And they will ask those scripted questions for debriefing. And they're probably going to hold on to that card until they really get comfortable with it to really make it their own. I love it. Thank you. So good, Robert. Exactly. Because creating a scenario requires experience, right? And if this is the expert simulation asking their mentor, educator needs more understanding of their mentorship role. When they ask their new, that means that expert really don't understand their role, right? And they don't understand the level or what they should delegate to simulation educators on different levels. This is a new simulation educator. So when you're reading those questions, make sure you understand and not pick, oh, it should be. But in this one, they're asking you what's wrong, right? And you would not ask a new simulation educator to create a scenario on their own. Creating a scenario should not be a part of a new simulation educator role doing. And guess what? It's doing orientation too. Woo, that's really rough, right? The timing is not correct. I agree. At this time, we should really just have them shadowing, right? And having them chime in as needed, but really in orientation, let me show you, let me role model. Scenario development should come later. Novice simulation educators should observe simulations being completed and demonstrate debriefing before implementing the simulations or debriefing themselves. Using an existing scenario may be more of an obtainable learning session than creating a scenario from scratch. Creating a scenario takes experience and maybe one that's simple and not complex either, right? 5, we're here in Brenner's developmental stages. I think we touched a little bit on that last week. What Brenner's development stage? At which of Brenner's developmental stage should the simulation educator mentor consider the new simulation educator independent? Is it during the novice stage, advanced beginner, competent, or proficient? D is correct. D is the correct answer. D is the correct answer. So in our question, what was your word or words that stood out to you and led you to choose the answer D as proficient? What was the word in your question or words? Anybody like to share?
Independent.
Independent, exactly. Independent. And so if you covered up your answer choices and you read that question in your mind, would you have picked proficient? Okay. In your mind, you can start going through your head. All right, novice, they're not independent. Advanced beginner, they're not quite there yet. Competent, they know, but when they're proficient, they can do some things on their own.
You know, I kind
Right?
of thought about this. I think it's the same thing with Benner. Whenever we teach new grads, like I think they're defined as when they finish nursing school, they're at an advanced beginner stage. And then I think about a new grad who just got out of a 1-year residency, they're competent. They don't become proficient until they're actually able to start making changes without somebody being right on top of them.
Mm-hmm. That's a good way to look at it. And they've advanced past those programs, taking their own patients, right? And nobody there to actually move them forward. They're actually out there doing their assessments and just moving those interventions forward, calling the doctor, and just all Miss Independent or Mr. Independent, right? It's a great analogy. At the proficient stage, the new simulation educator should have completed enough orientation and have received enough mentorship to be independent in the simulation laboratory because they are able to modify plans and are flexible in their teaching techniques. At the novice stage, the simulation educator is inflexible and really task oriented, focus directly on those steps. Don't come out of it. They're not. If you throw a different move, if the students move them out of what is scripted in that scenario, a lot of times they are very challenged. It can be a little challenge. They're not able to do a sim on the fly. They need that structure. And the simulation educators and flexible focus on the task. The advanced beginner is starting to recognize meaningful pieces of a scenario. A competent educator is able to organize and plan, but may not have the ability to know how to do the job and does not have enough experience to be independent. And I know with this one thing that I did in addition to what Robert is talking about was I was able to say, people in my center, tag names to them. Oh, that person is at a novice because they need extra help. And that will help me when I started thinking about what they do. Right now, that's one of the things you can safely do versus, remember, I told you don't want to read your questions and think through the lenses that your center may not have this right here in order, or you may not be doing, some may be doing some bad practices in SIM. They're asking you to answer from best practices. And if so, you had everything. So don't read too much in it. But with this question, you can actually tag people's names to it to kind of help you if you're struggling with actually understanding and moving Brenners into your simulation. Okay. And that's another little helpful hint there. Okay, good. Number 6, an important concept in simulation learning is to understand that the simulation educator should A, coach the students as they move along in the scenario. B, provide details about treatments during the scenario. C, stop the scenario if it's not meeting the learner's objectives. Or D, allow the students to critically think and make decisions. Correct. Our answer is D. I love it. So tell me why. Oh, okay. Important concept in simulation is to understand that the simulation educator should. So this question is asking us, what are the expectations of a simulation educator? Does everybody agree? Yes. So when we look at our answer choices, coaching the students as they move along in the scenario, is that our expectations to coach?
No.
Nope. Coaching and facilitation is different, right? Okay. Are we supposed to provide the details about treatment during the scenario? No. We give our handoff report in pre-briefing. When we go over that pre-work, we're talking about that then, right? But we're not going to have them in the simulation and spoon feed them through. That's not our role either, right? We're going to allow them to do the simulation. As long as they're safe and everybody in the environment is safe, then we'll talk about those behaviors when we get where?
Debrief.
In our debriefing, exactly. So you're not going to guide them about the treatments. Nope. That's something we should have talked about before we got into simulation. However, if they need to do a timeout, we can do those timeouts, right? But that's not what this is talking about. C, stop the scenario if it's not meeting the learning objectives. Is that something you want to really do? Is that the simulations educator's role is to stop that scenario if we're not meeting the learning objectives? Well, if we have time to continue, we can see what we can do to help guide them, maybe do some timeouts, maybe do some other lifesavers to see if we can help them, but that's not our choice either. When we look at D, that choice just speaks volumes, right? It really outlines something that we as nurse simulation educators should be doing. Allow the students to critically think and make decisions. That's one of the highlights and outcomes we can get when we put them in a simulated environment, is provide those scenarios that can cause them to critically think, right? To connect the content from the classroom, the didactic, what they've learned there. They come to the sim lab. They've already gone to skills lab. We bring them in the simulation room. So they're bringing content from the classroom, from the skills lab, and we're bringing them in that simulated environment so they can connect the dots, connect it all, right? And put that out and implement it into practice in that simulated psychological safe environment, right? So we're allowing them to critically think, and then we can evaluate and provide them feedback into debriefing, but we need them to make their decisions. So D is the correct answer. Creating a psychological safe environment is important. And when does that start? When do we start creating a psychological safe environment? Where does that start? Exactly. And do we just say it there and stop?
No.
No, you want to go ahead and you want to facilitate that throughout your entire experience. Now, at the top of debriefing, sometimes you have to reinforce that, because guess what? They've went in a simulation, and if your students are like our students, they come out, they're all over. So we still have to kind of remind them it's okay. The feelings that you're feeling is real. And I tell my students sometimes, you know what, we did a great simulation because you're feeling what you're supposed to feel. So we want to continue to keep that environment safe for them. We introduce it, establish it, and we set the tone for it in our briefing, but we want to make sure we carry that throughout the entire simulation experience. Simulation learning is hands-on, in which students are encouraged to make decisions and think about possible solutions to patient issues. Coaching during the simulation scenario may be necessary at times. Providing details should not be necessary during a scenario because it should be completed during the pre-briefing. Stopping a scenario should only be a last attempt at getting the students back on track. So we'll try to save that scenario as much as we can. Okay. All right. Got to pick up a little speed. An effective method for advocating for simulation would be what? A, appointing simulation educators. B, designating shared space with other learning activities. C, recruit interested faculty. Or D, reusing equipment to decrease costs. C is our correct answer. Yes, C is our correct answer. Recruiting interested faculty. And why would C be the answer? What word or words in your question provided you the context to select C? We
Advocating.
talked about this a little bit last week too. I'm sorry, Ms. Meyer.
Oh, I said, is it advocating?
Exactly. Yes, advocating for simulation. And when you look at C, recruiting interested faculty, because if they're interested, do you think they're going to do better in your SIM center versus those you forced to come?
No, they'll do better.
Exactly. Appointing those simulation educators, may not be an effective method, but guess what? Again, now, don't you look at it through the lenses of what you have to do in your practice. Best practice say, find those that are interested, right? Okay. This is one of the ones you can't look at, what may be done or what you've observed or what you have to do. This is what best practice say. Get those that are interested, advocate for them, get those and pull them in, bring them in, and you'll have a better chance of having them really do really well in simulation. Designated shared space with other learning activities is not, and reusing equipment to decrease costs. Okay. Faculty that are interested are more likely to demonstrate enthusiasm for simulation. Learning, appointing faculty may not produce advocacy for sim education if the faculty are not passionate about sims. Designing shared space with other learning activities may not keep the simulation equipment safe, and reusing equipment may not produce good results if it is outdated or in poor repair. Number 8, a novice simulation educator needs a better understanding of the benefits of simulation learning when they say, I should use simulation for A, common assessments that the students do every day in direct patient care experiences. B, hard to acquire patient scenarios that meet the student learning outcomes. C, assisting students in understanding a team collaborative approach to patient care. D, providing experiences in caring for diverse patients that may not be encountered in direct patient care experiences. Correct. Our answer choice is A. So someone please tell me. Common assessments. A novice simulation needs a better understanding. Better understanding. So that's telling us what? That the answer choices are not true. Right? Of the benefits of simulation learning. I should use simulation for. So when we're looking at our choices, A is our correct. Common assessments that the students do every day in direct patient care. Is that true? With Sims, we're looking to do those scenarios and situations that they really don't have an opportunity to do, right? That's one of the powerful outcomes or the opportunities to use simulation. B, hard to acquire patient scenarios that meet the simulation student learning outcomes. Is that one of the benefits of simulation? Yes, it is. C, assisting students in understanding a team collaborative approach to patient care. Yes, team steps at its best. Code Blue Sims, right? D, providing experiences in caring for diverse patients that may not be encountered in direct patient care experiences. Yes, that's another reason for simulation. So if that novice simulation educator say they're using simulation for A, they need a little bit more understanding of the benefits of simulation. Okay. A better use of simulation is to expose students to team activity, hard to acquire patient care experiences, and diversity not encountered in direct patient care experiences. Common assessments and competencies that the students do often in direct patient care usually do not need additional practice in the simulation laboratory. Number 9, a method a simulation educator can use to promote student engagement is to A, use high-tech equipment, B, review pathophysiology, C, review the student's learning outcomes, D, provide a complex scenario. Yes, our answer is C. The answer is C. Method simulation educators can use to what? Our phrase is promote student engagement. How do we promote that engagement? By using high-tech equipment?
Well, high-tech
Do you really
equipment
have
not
to have
needed for
high-tech?
every simulation.
Hmm?
High-tech equipment isn't needed for every simulation. It depends
Exactly. And
what's
students
running.
sometimes don't want to engage. Sometimes they don't know how to use it.
Right.
Right? Yeah. Review pathophysiology. Will that increase student engagement or promote engagement? They may understand, but will that cause them to really be engaged? And if you have your introvert, they may not still want to do much, right? And understand all the patho you've given them.
I
What
remember the
about,
book.
hmm?
I remember the book said didactic learning should be done before they get to see them anyway.
Exactly. There's no time for us to teach. That's why we really have to we're learning best practices. And that's a fine line because sometimes I really struggle with that because especially if you're in the classroom, when you get the simulation, it's a fine line. Before you know it, you're going out straight teach mode. Like, oh my goodness, we're back to the classroom. So you're right. They should get all of that before they come. Those concepts should be touched on. We're coming here to help them do what? Bring it all together and to see where there's a gap. Maybe it was in the classroom. We might have to go back to Course Falcon and say, well, they didn't quite understand the concept of congestive heart failure or fluid electrolyte imbalance. Because we noticed in simulation, they really struggled when they saw the lab values. Or it could be a gap in what? In the skill portion, psychomotor. We may have to go back to the clinical lab instructor and say, hey, they really broke sterility a lot trying to put that Foley in today. Or I noticed that they forgot the 5 rights. Oh, you see? So that's what you're right. Simulation is not that place, right? But we can review that patho, and some of our pre-work assignments include them what? Having to go back for patho and kind of look at it. But will that increase engagement? But when we look at when we look at number C, review the student learning outcomes. Yes, because if they can understand that, you can increase buy-in. Students can say, oh, this is why I'm here. And not only that, when we really go over our learning outcomes and make sure they understand it, I always like to circle back around and say, now, do you think together we're going to achieve those learning outcomes? They say, yes. I'm saying, I believe that too. And then you let them know just how much you believe, that they're coming here. You're coming here to do your best. And we believe the best about you. Right? Okay. So C, increases student engagement, that they understand a little better and where they're going, what they're going to be doing, the objectives and activities. It really helps with that. Meeting the student learning outcomes with assist in providing a learning experience that is appropriate at their level and using the appropriate content. That's very critical. When you're doing your learning objectives, you have to make sure they are what? Appropriate for the level of your students. Correct? You're not going to give higher level objectives to your fundamental students. That should stay with your what? Your advanced students, your higher seniors, right? So that's another thing we have to be very careful with, even as we're creating our objectives. Appropriate level and using the appropriate content. Do they understand it? Have they talked about it in the classroom before? Okay. This will provide students with the best method of engagement because they will make the connection, yes, between what they've learned in the classroom, in the didactic content, and their learning experiences. And that could be where in their clinicals, in their skills labs, et cetera, et cetera. Using high technology does not guarantee results and should be used for scenarios that call for technology. Again, when we go through our chapter that talks about your modalities, you have to make sure you choose the appropriate modality to meet the learning objectives. You may not need a high fidelity simulator to do a simulation that's really looking at psychomotor skills. You can do what? And I'm gonna test your little head. What type of modality would you need for just a task trainer? Yes, I love it. I love it. A task trainer, right? And if we're doing another a simulation and say we have a standardized patient, right? And we need to do an IV. What type of modalities could we use for that one? We already have the SP or the standardized patient. Or do we need to have a high fidelity simulator in that simulation? I should have told you that. I got so excited. I gave you one.
Well, not necessarily if you're trying to see what the students' emotions would be, putting the IV in and getting them more used to that aspect of it. Then no, I mean, you could use a standardized patient.
You can, but what else do I need?
Task trainer.
Yes. So we've got us a hybrid sim. Come on.
Yeah.
We got a hybrid sim. So we put that task trainer in there and we use our standardized patient and we've done it, right? Modality has to line up with your what? Your learning objectives, your learning outcome. There's no need to use, you don't have to. Yeah, I just love it. I'm getting ahead of myself. I get excited. So y'all have to bring Dr. Scott back down because we got a little agenda here to do tonight. I get so excited. Oh my goodness, that's how it is when we are with our learners, right? When they're pulling together, you and that debriefing and that, I say debriefing and learning, simulation like popcorn. My mom used to pop popcorn on the stove. We do the old way. You put that pot on there, put that oil. I still do it today. The best popcorn in the world. And once it start popping, guess what? It just, that's how it is in debriefing. You ask the right questions, those Socratic questions. You're not in at a lecture, but you ask the appropriate questions. One gonna pop off the other. And then you got a whole room full of popcorn. A whole room full of learning. But guess what? It happened in a safe environment, right? Okay, Scott, come on. Number 10, a simulation educator is observing the development of a scenario. The simulation educator is most likely in which stage development? A, novice, B, advanced beginner, C, competent, or D, proficient. And I know we're going to get 100. Exactly. We've talked about this a lot. So do you think that's going to be on our CHSE exam development? I think so too. I know so. Yes. A novice. Because again, they are doing what? What is your key term? What is your key word in your question?
Observing.
Observing. Exactly. And if you covered up all your choices, when you saw observer in your mind right then, novice should have popped in your mind, right? But if not, don't be hard on yourself. When you uncover the answer choices and you look, it should have came right up and hit you in front of your face. That's it right there. But what I'm challenging you to do, even if you know the answer, I need you to go through each one of those choices and you need to speak out loud or you need to write down on the paper, however best you learn, why that answer is incorrect. Okay. And the answers that are correct, you need to tell yourself. And if you have a nice little study group outside of this, some people like to study alone. Some people, we are here together doing a great job. You need to be able to tell yourself out loud or either write down why that answer is correct. Okay. We're at number 10. It's 6:48. We're here. We should be taking our first break here. It's 6:50. We would go on our first break for about 15 minutes. So I'm going to let us go. Everybody good? Thumbs up, thumbs down. You guys are doing great tonight, just like you did last week. Okay, so we're going to take our first 15-minute break. We were supposed to get through 4 and 5, but I got excited. And I was going a little slow. So I'm going to pick up a little speed when we come back, okay? And I need you to talk to me now, because if not, Dr. Scott get to talking, we might be. Come on. All right. But we will come back. And so I'm going to add chapter 5 to our next set of questions. So we'll do 20 questions our next run. And we'll do chapter 5 and 6. We'll have one more break, and then we'll finish up with chapter 7. So everybody good? We'll cut our cameras off, cut your mics off. I'll pause the recording, and I will see you back at 7:05. Hope everybody had a good break. We're ready to fast forward. We're getting ready to go to chapter 5, special learning considerations and simulation. Page 61. Everybody ready? All right. Number 1, the simulation educator observes a student crying after the death of a cardiac patient, portrayed by a mannequin in the scenario. The simulation educator understands that this can happen because simulation is A, an unfair social practice, B, an intense learning experience, C, an emotionally charged situation, D, a situation involving students with unpredictable personality types. Correct. Our answer is C. Anyone would like to share briefly what helped you choose the answer? What was in your question? I was A, B, and D incorrect.
Simulations used to teach social practices like ethics. Not all simulations are intense. And students with unpredictable personality types. That's why you have to do a learning eval or needs assessment, or I'm trying to think of the right terminology.
Needs.
So C, emotionally charged, because you never know what scenario you might put them in.
Exactly. And this one is what cardiac death after a cardiac patient. Death of a cardiac patient portrayed by a mannequin. Well done, Robert. An emotionally charged situation may occur if the learner relates a simulation to a situation that what has occurred in their life or that a friend or family member. Those emotions can be evoked, right? And then you're right. That is one reason why we really want to talk to our students, but also be sensitive to them as well. If they need to step out, we have someone that can actually check on those students, correct? Just to make sure everything is okay. The scenario does not depict unfair social practices, so this should not be the trigger for the student. Intense learning experiences are usually complex, with many things going on at once, and higher level students should have the resiliency to react in these situations. Unpredictable personality types do not necessarily mean that a student will become emotionally upset. This scenario really depicted it met the students where they were supposed to be, right? And if they did have a past experience, guess what? These emotions we would see. So this is an emotionally charged situation. Number 2, simulation learning activities can lend themselves to a better understanding of human diversity because A, they are faculty who can adjust scenarios. B, many laboratories have diverse mannequins. C, it is a reflective learning environment. D, diversity can be discussed during a scenario. C is correct. So let's talk about that one. Who would like to share? In your question, simulation activities can lend themselves to a better understanding of human diversity. What in the question helped you choose C? Or A, B, and D were incorrect? Who would like to share?
Whenever you're talking about diversity, you need to be reflective, and in Generation Y, most of them like to journal, and they're the most diverse group. And then also in Kolb's learning experiences, when they go from concrete to reflection simulation, they're going to reflect on things. So that's kind of where I went with that.
I love the way you brought in Kolb's as well. That's a great way to roll that out in simulation and see it presented. In reflective learning environment, and we're causing them to like look back on their behaviors, right? You're really able to hear it from a collective approach, right? Hearing what everybody has to say in that situation, in the simulation, debriefing about that simulation itself. So that really helps us out a lot. Many laboratories have, that's true, but it's not really the main necessity. And C, we want to make sure that it's also talking about psychological safety. And where do we say psychological safety starts? Where do we initiate a role psychological in pre-briefing, briefing? Correct. Correct. So we want to set that stage because guess what? If we do that, students will be more open to reflect, right? They will feel like they can share their true feelings, right? They'll feel like they're not going to be penalized. When they're feeling like that and they're climbing up, that means our psychological safety has been broken or not established well. Sometimes it can be established, but it can be interrupted, right? That's why you have to really, as the simulation expert, you have to really, you're almost like a mother hen. You have to protect your simulation environment from other faculty that come in and don't understand simulation best practices. That's going to be you. You're the one that's going to protect your students and protect that psychological safe environment. Okay. All right. Learning to reflect is a primary simulation experience, and reflection leads to understanding unconscious biases and tolerance and appreciation for diversity, inclusion, and equity. Diverse mannequins assist in recognizing diversity, as do discussions about diversity. Faculty can adjust scenarios to include diversity, but understanding is really a product of reflection. And that's what happens in that debriefing. Those Socratic questions, asking the right questions so that they can look back on that behavior. I noticed that you did not look at your ID band or ask that patient their name before you gave the medication. Tell me what you were thinking. We're able to hear what that student's saying. They can reflect back on that behavior, and then they're more amped to change it versus you sitting there reading it out to them and telling them why they didn't get it wrong, why they didn't get it right. Okay, students' learning styles are important to understand, so the educational methodologies can reflect student preferences. The simulation educator should be aware that preparing the night before the simulation scenario is most likely best suited to learners who prefer which learning style. Okay, we're looking at VARC, right? Visual, B, read write, C, aural, or D, kinesthetic. Okay, I love it. Miss Free, come on and talk to me tonight. You sitting over there. What you think about that answer, young lady? You want to share with me, Miss Free? Share with the group why you chose B. B is correct, ma'am.
So I chose B because I have a lot of students that like to read and then write down all of their notes and kind of scribe it down so that as they're learning, they're able to have a tactile piece as well.
Exactly. I love it. And I love the way you were able to connect that one with your students. This is a question where you could do that, right? And I love it. And so if you're struggling with learning styles, that's a great way to remember them. Just pick out some people, some of your students in your group, and start attaching their names to it. Okay. Even some of your family members. Sometimes I say, oh, my family member loves to do this. Attach your family member's name to it. I also made up songs. I love music. So you can make up a lot of cool things, right? They help you memorize. And the thing is, they're not going to ask you to recall, to tell the definition. They're going to give you a little brief little study, and you're going to have to pick out the right answer. Am I making sense? Great job. Thank you, Ms. Free. I love it. Visual like graphics, read write. They like PowerPoints or written prefer to read. And our other audio, they like what? The listen. They learn best by that. And your kinesthetics, they like the what? Touch and do something, right? Okay. So remember your VARC. Okay. Good job. Learners who primarily use the read-write mode to learn would benefit from having time to read over the scenario the night before. Okay. Visual, aural, and kinesthetic learners are more suited to learn doing your pre-briefing, because we do a lot of that in pre-briefing. Good job. Thank you, Ms. Free. 4, a simulation educator is facilitating learning about a procedure, and one of the learners has difficulty following the steps. The learner may be displaying characteristics of which learning type? A, tactile, B, intuitive, C, global, and D, reflective. I love it. It is C, everybody. Correct. It's C, our global learners. Okay. Following the steps. Oh, see there, I did it again. I tell you, I'm just having me a ball tonight. Following the steps, that's in the question. So if you were covering up your answers, you read the question, which group of learners like to follow steps, right? And that will be our global learners, okay? Global learners many times will see the big picture before the details and therefore may have a challenge with procedures. Tactile, intuitive, and reflective learners may be more in tune to the procedural steps in a process. Okay. All right. They like to look at the whole picture. Again, attach student names to this or attach family members. The overall thing they're wanting us to know as experts, as simulation educators, experts, is that we understand how to tailor the appropriate scenario, right, to our learners. And that we do in our briefing, in our planning stage, when we're developing our scenarios. That's when we decide all that, right? We're not going to do that in pre-briefing because we should have done that before. Because that's what's going to help you develop that scenario. We understand our learners. Our learners have a very diverse group. We need to make sure we're hitting all of those learning styles so that we're able to meet those students where they are so that they can achieve their objectives. Everybody agree with that? So number 5, many simulation educators are baby boomers or Generation Xers, while learners are millennials or Generation Z. One of the learning strategies that millennials and Generation Z respond positively to is A, modular learning, B, lecture before the scenario, C, problem solving, D, group activities. I love it. The answer is C. Again, they're not asking you recall, but we got to know and understand what these different type of learners, how they think and how they learn, right? And what groups learn best together. Because again, that's what we're doing. We're developing scenarios. We're pulling groups together, right? And even have the opportunity to put students in different groups. So making sure that we're structuring those groups very well as we're aligning our scenarios to our learner groups. But C is correct. And again, you can attach people in your class. You can attach different cohorts. You can even attach family members. Well, grandma so-and-so, she was like this. Well, auntie's like this. But my children, they like this. And now, you know, my teenage cousin, she's off the chain. So you're able to connect and put people's names to them because you're going to remember that when you get to your exam because you're going to remember their characteristics, okay? Not for recall, but to be able to recognize it in the small case study and be able to pick the appropriate activities, okay? All right. All right. Both groups both groups learn well by problem solving. Millennials like teamwork and group activities. Modular learners and lecturers are most akin to baby boomers and your Generation X. You can even talk about yourself. What group are you in, right? Okay, here's another one. Guasha's teaching style describes simulation educators who have different approaches. The best approach an educator can have with a group of learners in a simulation scenario: A, expert, B, formal, C, demonstrator, or D, delegator. Oh, yes, I'm loving it. Yo, ooh, wow, wow, wow. C is correct. And again, we're not looking for recall, but we're looking at what this expert, formal, demonstrator, delegator. What is the best approach we would have as an educator? Demonstrator. Coach, but not coach. Facilitator, but demonstrating. Okay. The demonstrator is correct. Demonstrators coach, demonstrate, and encourage active learning, which is congruent with simulation learning. All of that goes into what we do as simulation educators. Expert formal and delegators do not what? Encourage student activity learning directly. That's where we're out there just telling them what to do. You're not going to have a nice psychological environment because they probably experienced that in the classroom. Or, SIM's supposed to be where they can really feel safe to talk and engage on their own, right? And really have their own minds able to blossom out and tell us what they're thinking, and we're able to shape it into some healthy thoughts or healthy practices if it's not. 7, a simulation educator provided students with the topic of the simulation for the following day and asked them to research the patient's care. According to Quirk, which teaching style is this? A, assertive, B, suggestive, C, collaborative, D, facilitative. I love it. Yes. So what in your question? What are your key words in the question? If you didn't even know, what are the keywords that helped you do your answer? If you knew nothing about Quirk. Ms. Courtney?
Yeah, it says it asks them to research.
Exactly. Ask them to research. And it's the ask, right? To seek more information. Students look up information. So there's a suggestive. Suggestive educators use experiences to describe concepts and then request the learners to seek more information on the subject. Assertive educators do not use facilitation. They're like, whoa, 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 whoa. This is what you're going to do. Collaborative and facilitative educators use problem solving because that's causing them to come together, right? And reflective learning as opposed to enhancing students' ownership of learning by suggesting they participate in information finding. Number 8, the novice simulation educator is reviewing the characteristics of teaching effectiveness outlined by Kelly and needs further review when they state that blank is included as a trait of an effective leader. A, feedback, B, communication, C, knowledge, D, sensitivity. Sensitivity. That's exactly right. Sensitivity. Sensitivity is not an attribute identified by Kelly. Kelly's research demonstrated that the 3 main attributes for effective teaching, feedback, communication, and knowledge of the content. And that really makes sense, right? Right? Providing that feedback to the students, having some healthy communication with them, and the knowledge of the content itself really, really helps us be effective teachers. Okay. 9, the social determinants that may place a student at risk include A, lack of friends, B, family members, C, lack of diverse faculty, D, peer support. Correct. Your answer is C, lack of diverse faculty. Can put them at risk. The more diverse, the more the students are able to relate, right? Lack of diverse faculty is a challenge for diverse at-risk learners. Peer support, friends, and faculty support may be factors, but lack of diverse faculty has been a well-documented determinant in at-risk student success. Lifesavers, one of my favorites, are sometimes needed in a scenario to promote positive learning and to A, decrease emotions, B, understand health and illness concepts, C, reach the learning outcomes, or D, develop a plan of care. It is. Someone tell me what lifesavers are, or give me an example. The correct answer is C.
The cue that you use that's unplanned to get the simulation back on track.
Yes. Woo, woo, woo. Yes, Robert. Exactly. And I love it. I love it. Because sometimes you may have to play the patient. You may have to, your computer don't have all of the choices, the vocabulary. The students are saying things to you. It may not be already inside of your computer, your platform. So you have to give them some extra cues, such as you want them to listen at their chest. Patient has some crackles in the lower bases. Patient has pneumonia, right lower lobe. So we have some consolidation in that right lower lobe. And they're not even looking at that. The patients start coughing. They say, I'm short of breath. They don't do anything. They just kind of like, we'll keep asking them questions. Well, do you want some water? And then they elevate the head of the bed. We want them to assess that patient's lungs. So we start coughing really hard. And then I still can't breathe. You start dropping the sats. You're hoping that they're going to do what? Do an assessment of the lungs. So you can be those cues. You can do those lifesavers either as you being the voice of the patient, or you can also manipulate the mannequin. You can manipulate vital signs. You can even have someone, I've had the CI to go in the room and just say something. Or we've had a family member that was sitting at the bed of a pediatric sim, and I would prompt that mom to say, what's going wrong with my son? Why are you da? And, just those things that kind of help save that simulation. Lifesavers are those cues, those things that we do that help save the simulation so that the students can reach the end. They can meet those learning outcomes. That's why we need to know what those are. And if your students are struggling, guess what? That's something we can port back to the class, the didactic, because we may need to do a little bit more of that content and talk about those signs and symptoms, because in simulation, they wasn't able to bring it together. Same way it is with assessment. If the mom is doing the nurse is doing a pediatric assessment, and mom is sitting at that bed, and that student is not putting that diaphragm at the right places in the heart assessment, we can have mom say, that nurse before didn't do that. You sure you in the right place? That's a cue, hoping that student's going to check and make sure, I might need to go back and make sure I'm doing my assessment right. So I love lifesavers. So don't forget that, because lifesavers are very critical, and they're able to help save that sim so that they can reach those outcomes, meet those learning objectives. And you do all you can before you have to stop that simulation. So you want them to reach those learning outcomes. It can be an embedded confederate, other actors, patient voices, the scenario design. Could do a whole lot of things, some cues that can happen in maternity. You can say, mom saying, oh my goodness, feel like I just felt a gush, because they didn't check the peri pad. They was just doing other things. But you want them to see, guess what? This is a postpartum hemorrhage sim. So you may have her say, oh my goodness, feel like something's wet on my legs. They're going to start looking to see, guess what? Now she's done what? We have some more bleeding, and that pad is saturated. Not only is the pad saturated, but the chuck pad and everything else. So those are your examples of some cues. Everybody good with that? Changing the scenario to meet student learner outcomes is needed if the learners are off track. Decreasing emotions should be handled during when? Pre-briefing and debriefing, right? Unless it's to the point that it's unsafe. You do not want the students to be unsafe. If there's emotional outbursts, it's causing the student to be unsafe or those around them, we do need to remove, and guide out and do a timeout, right? Because you don't want no one to be unsafe physically. Content, understanding, and developing a plan of care can also be addressed doing pre-briefing and debriefing. It's not the time to really do a whole lot of that during your scenario, because then you can actually break the realism of the simulation, and then you'll have to start all over again. Everybody good? I tell you, we got some really good things going here. Let's see, y'all ready to move on to number 6, chapter 6, interprofessional simulation? Okay, we're looking good here. We're looking good. I think I'm going to keep moving on. We're supposed to take a break at 7:30. Y'all feel good? Let's go ahead and do chapter 6. I was getting ready to put my thumb up. You have to put your thumb up. All right, good. Let's go. Interprofessional simulation. I'm going to tell you, you really need to understand the tenets of interprofessional simulation. You really, really need to understand each one of those on the learning, each domain. You need to understand that. And I have a handout for you to see how each domain is rolled out in simulation, because you'll have a little short scenario that can really lead you. You have to figure out or choose the answer that's appropriate for what domain is being observed at that time. Okay, so please make sure that you understand on page 74, those different domains: interprofessional communication practices, roles and responsibilities for collaborative practice, values, ethics for interprofessional practice, interprofessional teamwork, and team-based practice. Just really understanding each one. And again, please check your resources that you have and look at it, what it looks like in a simulated environment. Number 1, the simulation educator is charged with designing an interprofessional education course with medical students, medical students, nurses, and pharmacists. Despite reaching out to colleagues, they have been unable to develop a team. The next best step is to A, move forward along and design scenarios that have a team caring for a patient. B, abandon the project and stick to domain-specific learning. C, locate an IPE case already designed and implement the program without support from other disciplines. Or D, reach out to the leadership of each discipline to discuss the needed resources and team members and understand their interests. I love it. Everybody's doing really well. D, because you remember this is team steps. So this is teams. This is teams. All right. Teams. So our answer is D. You do not want to do a scenario at IPSIM if it's supposed to be interprofessional and you have your medical students, your nurses, your pharmacists. If it's only nurses there around the table, the nursing faculty, you don't want to plan that IP and not have your medical faculty there. Because they know their field, right? They know their learning outcomes. They need to be contributors to that conversation. They need to be contributors to the learning outcomes as well. Because they need to bring to the table, what do you want your medical students to do? What do you want your nursing students to do? What do you want your social work students to do? So everybody who's a part of that interprofessional simulation need to be around the table in that planning phase. If not, we just need to keep working. And that's one of the factors that impact successful IPE planning and simulations. And I'm probably getting ahead of myself, but we'll come back to it. If you see it again, you'll just know the answer. What is the one things that really impact us having successful IPE sims, interprofessional sims? What do you think it is? One of the number one things.
Communication.
Communication, but what's one above that? We're trying to bring everybody together. We need to plan.
Oh, yeah.
What is it?
Logistics.
Yes, exactly right. Logistics, that timing. Your schedule is different from ours. Nurses, we have this schedule. The MD or the med students, they may be over there, they're doing something else. But we have to find a common time where we can get at least most of them represented at the table, right? So logistics, timing is one of the factors that really, really challenge us in the areas of IPE. How you can remember that? Just imagine yourself trying to put together a simulation with more than one cohort sometime. Or trying to reach over into another area. It's challenging. Because one thing they're going to tell you, oh, I'm in class that day. Oh, I can't do that. Oh, we got a test. Oh, we got an OSCE. Well, look, somebody's going to have to come over here because we're going to do this IP. You need to be around the table. Okay? So reach out and get all of us together. Tackling the barrier of needed resources need leadership support to increase the chance of success. Not partnering with leadership and other professions will not result in optimal IPE simulations. Moving forward alone will not ensure IPE or what? Using an existing scenario if there is no what? Buy-in. Because then that scenario is going to really be jaded, because if it's all nurses around the table, when the med students come in there, it's going to really be truly nurse focused, and they're going to be like, well, y'all didn't think about it. So you don't want that to happen. That's why everybody needs to be around the table. Medical students know exactly what the faculty know what their scenarios, our CRNAs. When you do scenarios, Courtney, when you're around that table, you know what type of simulations you want for your students, right? Sometimes it's a lot of times different than your nursing students. So all of us need to be around the table so that we can make sure that we ensure that those learning outcomes are verbalized and acknowledged and put into practice as we move forward in planning that scenario. Abandoning the project is not an option because communication in the practice area needs to be interprofessional to decrease patient care mistakes. So we need to do that. Number 2, the simulation educator over here is a participant of the interprofessional education experience, raising their voice loudly and stating an order to someone in a different discipline without addressing this person by name. The simulation educator would best handle this situation initially by A, exploring the action observed in the debriefing following the case. B, ignoring the behavior and focusing on medical management of the case in the debrief. C, reporting the participant to their supervisor for remediation. D, stopping the scenario, removing the participant, and restarting the scenario. Let's talk about it. I need to hear somebody's voice on this one. This is a good one. A is the correct answer. A is the correct answer. So please tell me in your question, what was some of the key things that was standing out to help you choose your answer? What was some of those things in the question? The concern was what we overheard a participant raising their voice loudly, right? That's not professional behavior. So that's okay. So they're raising their voice loudly. And not only that, they're stating the order to someone in a different discipline without doing what? Addressing them by their name. So those are some key things that fall in one of those domains, right? So A, what will we do? And it says handling this situation initially. It's not saying what you'll do second, third, or fourth. It's asking you what you're going to do what?
Initially.
Exactly. Ignoring the behavior and focusing on the medical management of the case in the debrief. Is that what would you do that first when this person is doing that? No, we're not going to do that first. We will do that, but that's not what we're going to do initially. Reporting the participant to their supervisor for remediation? No, we do need to address that behavior, right? So reporting them to their supervisor is not the initial thing we're going to do for remediation. And they don't need remediation. We need to talk to them about that behavior and find out what's the root. There could be some very concerning things that could be going on with the student. They could have had a trigger. We just don't know, right? D, stopping the scenario, removing the participant, and restarting the scenario. That would not be the initial thing to do, right? You start and stop. What are we doing to the psychological safety in that environment? What are we doing to the fidelity we've already established to that point? So your best thing to do initially is to explore the action observed in the debriefing following the case. And how would we do that? John, I noticed that in the simulation, when you were getting ready to do XYZ, I noticed that your tone changed. Can you tell me what you were thinking at that time? Please help us understand what was going on. Now, he didn't start hitting nobody. He didn't start turning up no table, so we don't need to stop it, but we just need to make note of that because that's something we really need to talk about. And then hopefully he'll start saying, I had a bad day, or I was getting frustrated because nobody was listening. Then we're able to talk about that. Not only that, did we also notice that you didn't address Jane by their name? And then we can start talking about how in teams we need to be what? Respectful, right? And acknowledge those that are a part of our team. And see, by the time you ask that in a very safe space, before you know it, I forgot what his name was, John, I think his name was John. He will be able to bring it back and he will be able to see, or she will be able to see that behavior was inappropriate, right? Especially in the midst of a team setting where we're working with different people on our team. That's respect, right? You see how that's rolling out? This is an opportunity to explore their thinking and impact of their action on other team members. And you also tie in and say, hey, Mary, how did you feel when John, addressed you the way he did? And that's an opportunity for Mary to really come clean. I felt disrespected. You made me feel like your way of thinking was important. If we have a psychological safe environment, your students will feel safe to do that and not feel like they're going to be penalized by you or their peers. But in the instance they start going back and forth, we as the simulation educators need to bring that psychological safety, maintain it. Okay, I noticed that we're getting a little, more involved in our answers right now. Are you okay? How about let's go to the next person, or we'll come back to you. We can do a nice little wraparound to maintain what? Psychological safety in that environment, but we must address it. Okay? Closed loop communication. Offer a new way of approaching closed loop communication. To ignore and not talk about the behavior during the debriefing results in a what? Missed opportunity to discuss interprofessional team communication. Reporting the participant potentially violates confidentiality and psychological safe learning environment, and stopping the simulation breaks that psychological safety for all of your learners. Okay. Number 3, the simulation educator working in a hospital-based simulation center is leading an interprofessional team designing a simulation-based education course to improve patient outcomes. To leverage the impact of the educational program, the team wishes to address the most common cause of error in authentic patient care. Which of the following will best serve that objective? A, lack of knowledge, B, inadequate resources, C, lack of communication, or D, lack of leadership. And you are so correct, communication. And Robert, you talked about that earlier. You're right. That leads to sentinel events. That leads to mistakes when we don't what? Communication. Now that is the number one thing that leads is communication. The failure to communicate, or guess what? Close that loop. Okay. So that's why we understand what closed loop communication is and how important it is. Yep. The most common is lack of communication. All the others can contribute to that, but when you're thinking about that number one thing, lack of communication is the most common cause of patient errors. Lack of knowledge, inadequate resources, and lack of leadership contribute, but are not most common, but not the most common cause of patient errors. Number 4. Simulation educators coordinate with an interprofessional team to design an interprofessional education course. Which of the following modalities will engage learners from all professions? We have A, in a virtual environment learning asynchronous reading case studies and answering questions. B, in an IP team, seeing standardized patients and co-developing a plan of care followed by feedback and debriefing. C, seeing a standardized patient by a group of professionals from one discipline and then writing domain-specific care notes. Or D, in a virtual learning environment where they take turns being the team lead in an advanced cardiac life support case. Correct. And our answer is B. Who would like to talk about that? Why is B our correct answer?
So at our college, we have to do a disaster drill every year with our paramedics. And one of the challenges we ran into this year was actually matching their learning objectives up with ours. So whenever I seen this question, I said, well, that makes a lot of sense, because you need to co-develop a plan of care. You need to make sure your learning objectives match up. And then as far as going by feedback and debriefing, you could do the feedback in real time, in a unidirectional kind of way, and then debriefing being bidirectional and going over to learning objectives at the end.
Okay. And I love the way you tied that to your school. That was very good for all of us to lay hold on that one, right? Anybody else want to share? Great job. Thank you, Robert. Which of the modalities, again, based on what we're doing, you heard that word modality, you're going to see it again threaded throughout. Because when we're looking at the modality that's going to best meet all of the learners, you don't just have nurses, you don't just have your CRNAs, you don't just have social workers. So what platform will help us bring all of that together in a very healthy way? Virtual learning environment, learners asynchronously reading a case and answering the questions, that's not going to be most effective, right? We need some interaction, right? B is our correct answer. I'll come back to that one. C, seeing a standardized patient by a group of professions from one discipline. And then writing, that's what Robert was talking about. That's not going to work either, because we need input from all, right? This is an IP interprofessional simulation. And this is a course, right? This is a whole course we're teaching, creating. And then in a virtual reality learning environment where they take turns being the team leader in an advanced cardiac. So when we go to be in an IP team, seeing standardized patients and co-developing, there we go, co-developing a plan of care followed by feedback and debriefing. That is the most successful IPE course you probably would have when you look at all your choices. I love it. Learners are interacting and IP teams are learning with and from. Then you go interprofessional and intra. Please make sure I have a nice document that I really give you some examples on inter and intra. You need to know the difference. Okay? All right, so please make sure that was a nice one we created in our last cohort, you're going to really make sure you understand that. So when they start providing you your examples. Okay. Asynchronous learning does not engage the IP team. Seeing a patient with only one profession present does not engage an IP team. Virtual reality can use an IP team, but in person increases interactions in real time. Okay. Number 5, the simulation educator is preparing to be in the role of a debriefer in an interprofessional team simulation and preparing for their role and reviewing the Institute IOM report. Which of the following should they anticipate including in pre-briefing to describe the primary reason the team is practicing? A, to decrease attrition from their respective professions. B, to increase efficiency of patient care. C, to increase communication across professions. Or D, to orient new team members. C is our correct answer. Pre-briefing to describe the primary reason the team is participating, to increase communication across professions. And that's one of the benefits of team IP, right? Working on communication. Yeah, we want to make sure we're having safe behaviors to have safe patient outcomes. But when you're bringing those teams together, we're looking at how we can better improve our communication. Okay, so to increase communication across professions. Interprofessional education simulation has been demonstrated, and there's research to show improved communication. The IOM report is about decreasing patient errors due to what? The lack of intraprofessional communication. The report does not address efficiency, orientation, and attrition within the healthcare. The simulation educator is leading an interprofessional team in a meeting and is explaining the essence of interprofessional education. Which of the following would best describe the essence of IPE? A, cooperation between different health professions. B, meeting accreditation standards and criteria. A licensure or certification requirement. Or D, to learn from, with, and about other. Exactly. To learn from, with, and about other. And that is what? Interprofessional. Okay. All right. I love it. Exactly. And don't forget to look at that resource document. Learning together is the core of IPE and is included in the World Health Organization definition. IPE is not a current licensure, certification, or accreditation standard. While cooperation is an outcome of IPE, it is not the core. The essence is learning together so that there is a team approach to patient care. In designing the interprofessional simulation case that will meet the core competency of roles and responsibilities. Okay, that's one of your competency or your domain. Which of the following cases would allow learners to meet that objective? Okay. A case where nurses, pharmacists, and doctors must form an ad hoc team to quickly provide care for an acutely decompensated patient. B, a case with nurses and doctors who must communicate a complex care plan to a patient and their family. C, a case with nurses and doctors who must resolve an IP conflict. D, a case with nurses and nurse practitioners where they must develop a complex care plan for a dying patient. A is our correct answer. A is our correct answer. So tell me why A is correct. Or tell me why B, C, and D are incorrect.
A, each of the different professions have to perform a specific job or task. They each have their own specific roles and responsibilities to care for that patient. Whereas the others, I feel like they're just working together to develop a complex care plan, or they're communicating, but they're not identified by their specific roles.
I love it. Thank you so much, Courtney. Spot on. You are. Exactly. Yes. So this is something similar. And that's why I want you to make sure you understand each one of those domains. Did a great job. More roles and responsibilities are in action in A. What's that, number 7? This would allow an IP team to practice the core competencies of the roles and responsibility. Communicate with patient families, and conflict resolution would meet the core competency of what? Communication. Nurses practicing with nurse practitioners is intra, because we're nursing the nursing. You see that? Inter is outside of our circle and profession. Nurses, social work, pharmacists, CRN, A's. You see what I'm saying? But when we're doing it together, nurse practicing with nurse practitioners is intra-professional. We could put our CRNAs in there because it's, yeah. Okay, so there's an intra within your profession and a inter outside. We're bringing others inside. So please make sure everybody got that. We're good with inter and intra. All right. Okay. I love it. I love it. Number 8, the simulation educators observing an interprofessional education case and notices the team asking for input from the patient and family for their wishes and for end-of-life care, as well as checking with all the professions in the room before developing a plan. This demonstrates the team meeting which of the following core competencies: A, values, ethics; B, roles and responsibilities; C, communication; D, teamwork. That's exactly right. Yes, A. So someone tell me why. Help me understand. What made A correct? When you're looking at your question, your little mini case study to us. What were your key words inside of your question that helped you pick values and ethics? Because that is correct.
Asking for input from the family.
Okay, asking for input from the family about their wishes for end of life, as well as doing what else? Not only from the family, but what else did they circle back around and do? They also included what?
Patient.
As well as checking with all the professions in the room. So we're kind of looking at everybody, right? Getting their take on it. Values and ethics. What do you think? How should we look? Respecting the values and the culture of others. You can clearly see that there. That's our values and ethics. It wasn't a role and responsibility like we saw in question 7. It wasn't a communication and teamwork. But look, this demonstrates values and ethics. Respect the unique culture, value, roles, responsibility, and expertise of other healthcare professions and the impact these factors can have in the decision, right? We're bringing it all together. Requesting patient and family preference is not highlighted under roles and responsibility, communication, or teamwork. Although there are components of them in the interaction, it is specifically under the values and ethics. So make sure you look at those. Number 9, the simulation educators design an interprofessional education curriculum between nursing students and medical students on different academic calendars and wants to proactively address the most common barrier. Now, I know y'all going to get this right because we've already talked about this. I don't even think I'm going to read the choices, but I'll go ahead and read them anyway. A lack of awareness of IP among faculty. B, scheduling different professions. C, misalignment with the school's mission and values. Or D, conflict among interprofessional faculty. And we said it's what? The logistics, the timing. I love it. So it is B. Remember those scenarios. Y'all probably have some real ones to go with this, right? Someone else always has something to do. All right. Number 10, the simulation educators evaluating outcome measures for an interprofessional education IPE program. Which of the following would be the best approach? A, do not use any outcome measures as this is a new program. B, review the literature and use a previously designed tool that is appropriate. C, realizing their center is different, create a new tool without reviewing the literature. D, use uniprofessional outcome tools and evaluate each profession separately. And our answer is B. I'm going to go ahead and keep rolling on this one because we're getting close to our time and I need to give you a break. Okay, we'll take our last break, but let me go ahead and do this one for you. B is the correct answer. You want to make sure they're talking about outcome measures. Do not use any outcome measures. Do not use any outcome measures. Is this a new program? We know that's incorrect because you need outcome measures. That just eliminated itself when it said do not use it. Number C, realizing their center is different, create a new tool without reviewing literature. You're not going to do that. You need literature to support your decision. So we know that's out. You need evidence-based to support what we're doing as far as our outcome. Use uniprofessional outcome tools and evaluate each profession separately. No uniprofessional. We need one that's going to connect all of us, correct? So that eliminates that one as well. B, review the literature. Yes, we're getting evidence research, right? And use previously designed tools that are appropriate. Yes, 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 and double yes. Why? Because we want validity and reliability, right? We want to use tools that have already been verified to have that. Correct? All right, we're looking at those outcome measures. This approach uses a tool with prior reliability and validity data. We'll look at that in some of our chapters coming up. Creating a new tool without the appropriate rigor process can provide inaccurate data. Not collecting data is a missed opportunity to evaluate the impact of the program, and using a uniprofessional tool will result in data that do not meet IPE. Now, if you do an IPE, you need it across those groups. Y'all ready for a nice little break? We got about 15 minutes. We can go ahead and take our 15-minute break. Or if you want to press forward, we can do that as well. If you want to take a small break, we have one more chapter. We're going to do chapter 7. It's going to look at ethical, legal, and regulatory implications in healthcare simulation. It's right now 7:56. So you tell me, what would you like to do? I think we could take a little break. You want to take a break or you want to press forward? Well, I'll let you take a break. Huh? I'm going to let you take a break because y'all moving a little slow for me. So go and take that little 15-minute break, and I'll see you back in a few minutes. Okay. Hope everybody had a nice little pause break, okay? We will go ahead and get started on page 95, looking at chapter 7. This is looking at our ethical, legal, and regulatory implications in healthcare simulation. Okay? All right. Number 1, a student is participating in a summative simulation activity and has failed in an area that has been identified as a critical element. It is clearly stated in the testing standards that a student misses a critical element, the student must fail the exam. The evaluator is rationalizing that the student's omission is an oversight and therefore the student should not be failed. What is the best action for the simulation leader / manager? A, leave it alone as the faculty are the experts. B, call an administrator to lead a discussion about the situation. C, inform the evaluator that their behavior will be reported to administration. Or D, discuss the situation, focusing on the potential ramifications if the students are ignored. That is so correct. Anybody want to give a brief reason why D is correct and all the other ones are not? Let me rephrase that. I'm going to rephrase that. Tell me why A, B, and C are incorrect.
Backward in, always experts. And honestly, whenever I looked at D, I mean, I know you said A, B, and C, why they're incorrect, but honestly, when I looked at D, if their omission was an oversight, when they become a nurse, what omission are they going to have, and who are they going to kill? So that's the reason why I picked that answer.
So ethically, we need to address that behavior, right? And there are consequences to that behavior. So ethically, it's the right thing to do. You need to discuss it and talk about the potential ramifications. Leaving it alone as the faculties are the expert, no, but you're the simulation expert, right? Calling an administrator, that just kind of really doesn't, it breaks confidentiality to a degree, right? And they're going to lead a discussion that you witnessed yourself. So D is your correct answer. Discussing the situation is the best alternative in order to understand if the learner and evaluator know the severity of leaving out a critical element. And I love what Robert said. You really want to connect that to real practice, because that's what we're wanting them to be, right? Safe practitioners. So this is one you can really tie to just what Robert, the example he gave, and causing the students to really see that happen. Ignoring it will not produce the student learning outcomes intended. And it's not ethically right thing to do. Participation in ethical simulation experiences is important for healthcare professionals because they can assist students in A, developing moral reasoning and recognizing professional values. B, learning to work out healthcare problems in a neutral way. C, focusing on the negative aspects of the healthcare profession. Or D, rationalizing behavior when making moral decisions. A is our correct answer. That is your priority, developing moral reasoning and recognizing professional behaviors. That is the participation in those ethical, that is the importance of doing that for a ethical simulation. Learning to work together, focusing on negative aspects of the health profession, rationalizing behavior. Okay, but our primary role is developing moral reasoning and recognizing those professional values. It's important to develop moral reasoning and professional values. It does not include rationalization, but does include reflection, going back on that behavior, reflecting on the consequences, and helping them wrap themselves around that and own it, so that they will change their behavior moving forward. It is not always possible to work things out in a neutral manner and focusing on the negative way. Negative may not build confidence in the students. Doing this in a psychological safe environment. The simulation educator is completing a summative testing session with students in an educational program. The testing session is about to start, but one of the faculty evaluators are not present due to traffic issues. The faculty member has phoned in and will be at least 60 minutes late. The simulation center leader / manager. Best decision is to A, have the students wait until the faculty evaluator arrives, step in as a substitute evaluator until the faculty member arrives. C, call in a substitute faculty evaluator with similar content expertise and training in the testing. Or D, inform the students that they will have to return and be tested on a different day. Correct. Our answer is C. And why is C correct when you think about the others? This is a good one.
This is a good, do as best practices and not what you do in real
Yes,
life.
exactly.
Because you might not always have someone with similar content expertise and
That's right.
training and testing to call upon.
That's
But
right, Courtney.
that is the best option because you want someone to be able to fill the shoes of the person who's missing and their expertise.
Exactly. And in your question is talking about what type of testing is this?
Summative, yeah.
Summative. That right there takes that question to another level. It's not formative, where we're adding to the knowledge, providing feedback. Yeah, we can fill in and give them some, but we're talking about summative testing, evaluation, using a tool that has been tested, reliable, and valid. So therefore you need someone that understands that tool, not just anyone coming in, because they're gonna evaluate and don't even know how to do it. So the results will not be valid. It won't be correct, right? So you need someone that understands how first to use the tool. So substituting is not your answer. And in our answer, it says they have similar content expertise. So out of your choices, they kind of fit the criterion to help you in this situation. And I love it. This is one of those ones, don't do as you do, but do as you know you're supposed to do according to best practices. Okay? You see that? And you're going to see it again, because when you're talking about your evaluation tools, you want to use tools that are reliable. And with our summative tools, they need to be trained. You need to be trained on how to do those tools. Okay? You don't want to make the students, you don't want to have the students wait until the validator come if you can help it, because their students' anxiety level is going to continue to go off the charts. And if they fail, they're going to circle back around and say they failed because guess what? You made them wait. And sometimes they don't do well. So that's not good.
Every time.
That's exactly right.
They're going to come back and blame you every single time.
Step in as a substitute evaluator until the faculty member come. No, if you're not a subject matter content similar to, or if you haven't even used the tool, you may be the simulation manager, but if you haven't used that tool, you wouldn't want to do that either. Right? D, inform the students that they will have to return and be tested on a different day. That can open up a can. You can probably do that if all else fail, right? All else fail, we'll have to reschedule your testing, right? But that wouldn't be your best choice and the primary thing that you'd want to do in this scenario. Everybody good with that? Good. The evaluator should be a content expert. Respecting students' time is important, and being free to manage the simulation center as the leader is also important. So we're even causing us to look at our role. You tie yourself down, and again, here we go. Don't look at what you're doing now. What does best practice say? If you're tied down there, what's going to happen to the rest of your center? What if you're the one-man person? You do it all. I've been there. I did all that, right? So when all else fail, I'm looking for that content person. If I'm not familiar with the tool, I need to have someone that can do that. Then if I don't have one and the other choices say you don't have those, then I would have to reschedule, right? That probably would be your best fit. This is good. Waiting does not respect the student's time. And guess what? What we talked about, it can increase their what? Their anxiety level. Stepping in decreases the leader's availability to deal with other issues. Should they arise, rescheduling this to be your what? Last resort, because usually there's a lack of time and space, and that's true as well. Okay, so we understand this question is making sure summative testing, the best person to do that is someone that has either expert content or similar, if that's one of your choices. And guess what? They understand that tool. They've been trained to do it. Number 4, students participating in this simulation scenario and must give a medication. The correct calculation to give the patient should have been 0.5 mLs of the medication, but the student drew up and administered 0.6 mLs. During the briefing, the student's response is that it was not a big deal because it was only 0.1 more milliliters than the desired dose of the medication. The facilitator's best response should be which of the following? A, well, it was not a critical medication, but next time, please be more cautious. B, any medication error with or without an adverse reaction is ethically important and should be considered serious. C, all medications should be given using the 10 rights of medication administration. D, ignore the student's response because they are embarrassed by the error. Correct. Our answer is B. That is the best decision. There is no such thing as an error that don't make. No. All errors need to be addressed because we're talking about what the outcome of simulation is to do what? Improve what? Patient outcomes and provide safe practices, right? So error needs to be addressed in a healthy way so we can correct that behavior. Well, it was a not, whether it was a critical, every medication is critical. All medications should be given using the 10 rights of medication. Ignore the student's response. That all of those are just unethical. Okay, it goes back to what Robert was talking about earlier too in his example. Reinforcement of ethical issues can accompany a mistake. It is important for the students to understand the error should not be addressed in an embarrassing way, but also cannot be minimized. Using the 10 rights of medication administration should be done for every dose medication. Now, I'm telling you, those rights, they seem like they change every day. Sometimes they're 6, 5, 4, 10. So just depending on what you use for your center, that's just a distractor, right? In that one. So don't get hung up on that either. 5, a group of educators is creating an end-of-life scenario. In addition to creating the details about the patient and the family, what other considerations related to designing the simulation are critical to make the scenario appropriate for the patients, for the participants? A, standards of care and culture of the region should be considered. B, skipping the pre-brief as to not disclose the simulation objectives. C, the scenario must be based on a real life situation. D, the scenario must include all healthcare disciplines. And correct, our answer is A. Yep. We want to include the culture of the region, which really adds to the realism of that sim, right? And it really makes it all come around full circle. That should be considered because, different cultural practices do different things at end of life, right? And that really makes that an authentic simulation. Skipping the pre-brief, we know that wouldn't be right because we need to do our pre-brief. The scenario must be based on real life situation, not really. It can be helpful, but that's not critical. The scenario must include all healthcare disciplines. No, not necessarily. If this was an IPE, correct, but that's not what it said. A student is in the hall discussing the last simulation scenario with their peers. They state that the standardized patient had HIV and was being told for the first time about the disease. The healthcare simulation educator overhears the conversation. The appropriate action by the healthcare simulation educator would be A, ask the students to take the conversation to a private room. B, call the student who was discussing the patient later and explain that the conversation breached confidentiality. C, stop the conversation and explain that it's a breach of confidentiality. D, explain to the students that if it were a real patient, this would be a Health Information Portability Accountability Act violation, HIPAA. Correct. Our answer is C. That is the right thing to do initially and always. Stop the conversation then, because guess what? You're addressing the behavior in action. And explain that it is a breach of confidentiality. Asking the students to take the conversation to a private room, they shouldn't be doing that anyway, right? We need to stop it. So that's incorrect. Call the students who was discussing later. No, we need to address it when the behavior, when we have the moment to do it. D, explain to students if they were a real patient. No, that is not the correct way. We need to stop, address the behavior. Okay. Number 7, a healthcare student states that they had a bad day and does not want to participate in the scheduled simulation scenario. The healthcare simulation educator should A, remind the student of professional expectations. B, excuse the student for the day and reschedule. C, have the student observe the scenario from the window. D, tell the student they can make with a case study. A is your correct answer, because guess what? We are developing professional behaviors. They just can't go to work and say, I don't want to do work. You might need to call in. So don't go there and tell them what we need to address that. They need to remind that student of their professional expectations, discussing the code of conduct, right? Ethically, what we're supposed to do as nurses. Of the profession, or which profession is in this sim. Excuse the student for a day and reschedule. Nope, that's not the right thing to do. That's not teaching professionalism. Have the student observe the scenario from the window. That's still unprofessional, right? We're allowing his unprofessional comment to go unaddressed. So that behavior will follow that student into practice, which can lead to what? Unsafe patient outcomes. If they end up doing that on their unit and then they end up being short and then someone end up having an issue. Tell the student they can make it with a case study. Nope, that's not equivalent to what we need to be done in this simulation. Number 8, the healthcare simulation educator wants to determine the intravenous administration competency level of junior healthcare students and then develop a module for remediation of identified weaknesses. This is an example of talking about summative evaluation, ongoing assessment, competency-based simulation, or formative. D, because you remember we're forming their learning along the way. We're providing them feedback, giving them opportunity to correct any gaps in behavior. Guess what? So that when they have that summative evaluation, they can actually be successful. Summative is at the end, right? The pass fail, right? Formative, we're forming learning. We're providing feedback, allowing them to change it. Provide feedback, allow them to change it. While they're doing it, we're providing feedback to change that behavior, forming learning along the way. D is correct. And that's exactly what they're doing. The term, okay. Got number 9, graduates from a healthcare educational program see an advertisement for the education organization on a billboard with their pictures in it from a simulation experience. The students did not give consent for the pictures to be used as external advertisement. This is an example of A, fair trade, B, extended use of educational materials, C, lack of consent, or D, academic freedom. Exactly. We need to get those consents. Even though you do consents inside of your center for educational purpose inside of your SIM, you take anything outside of that, we need to do a separate type of consent to make sure those students are okay with us putting their information outside of that academic arena. And that should be outlined in your policies. How do you store your content? How do you get your consents? All of that should be discussed with those students from day one. If you're going to do something outside of that with another group of students, go back and circle back around. Hey, I would love to use your photo for XYZ. Do you consent to that? Some universities do that. They cover us as well. But you as simulation experts, you want to make sure you cover it. So it's a lack of consent. 10, an example of a micro-ethical situation embedded in a simulation scenario would be A, administering the wrong medication to a patient causing an allergic reaction. B, forgetting to wash hands before assisting a patient to the bathroom. C, forgetting to identify the patient by two means and just asking their name. Or D, leaving a Foley in all night that was supposed to come out the morning before. B is correct. That's your micro. Now, it's not saying it's not, everything is important, right? But that's a micro, washing the hands. But that could still lead to big, serious, right? Transmission of microorganisms can cause our patients that are immunocompromised to really die. But that's considered a micro when you're looking at your choices there. Okay, A and D are major, right? They could say that's a simple thing to do, not washing your hands, but it has major consequences. Everybody, we've had a wonderful night. We're right at 8:30. Everybody doing well? You feel good? I want to commend you on a very wonderful night. I hope it's been very helpful for you. We have a boot camp on tomorrow, which will be an hour session. We'll probably look at the next session on our test plan. You are free to join. You don't have to pay for that, but you do have to, I think all of us are registered. If not, check the platform, email me if you still want to join. It'll be a nice opportunity if you just want a little bit more. We're looking at the test plan. I did domain 1 last month, and we'll be looking at 2 on tomorrow. So if you want to join, it's from 6 to 7, and it's free for you to join because you've already paid for the course. So if you want to join me, that's fine. If not, I'll see you back next Wednesday. I hope y'all have a wonderful rest of the evening and week. We will be looking at chapter 8 through 13, healthcare and simulation knowledge and principles when we come back next Wednesday. Okay. And Robert, don't forget to email me just to remind me that you'll be away. Okay. All right. Andy, take care out there. We miss seeing your face today, but enjoy the conference. Okay.
Thank
and
you.
everybody
Have a
else,
great
y'all
day.
take care.
Bye. Thank you.
Good night.
Bye.
Bye-bye.